the lecture by Dr. Corinna on surgery indications and techniques. I request Professor Corinna to share the screen, please.
Hello, good morning.
Good
Can you
morning.
hear me?
Yeah, we can see your screen.
And can you see my screen? Wonderful.
Yeah. Yes.
Okay, great. Well, I wanted to thank you very much, Dr. Panigrahi, and thank you, Dr. Zaleli, for the opportunity to be with you this morning from California. And I was asked to speak about surgery for metastatic spine tumors, indications, and techniques. And I will say that the two prior speakers have done an amazing job of speaking about indications. So I've deleted some of my slides and I'll go through the indications very quickly. And then I'm very excited to focus on some of the fun parts of doing the surgery, which I know that many of us as spine surgeons really appreciate. Okay, so let me move forward here. So we talked about this very, very nicely already, but anytime a patient comes to me with a metastasis to the spine, I'd like to know what's the primary tumor, their extent of extraspinal disease, of course, their neurologic status, and if they have a deficit, how long has it been going on for? Days, weeks, months, or years, because this is really important in terms of how I'm going to think about the acuity of the intervention that's needed for them. We've talked about the importance of spine stability measured with the SIN score. We've talked about the importance of the patient's prognosis and then their overall well-being for surgery, which you can assess with various measures, including Karnofsky scores and an assessment of their overall medical problems. We've already talked about radiosensitivity of tumors, and we know that some are very radiosensitive, medium radiosensitive, and usually more radioresistant. And there's obviously important nuances to that depending on the type of radiation. It's important for me if I'm considering operating on a patient to know whether the patient's had radiation to that area, what type and how much. That's particularly important because it's also going to tell me about, one, do they actually need surgery at this point? And two, what's the bone quality going to be like when we're going in there? So that's a really important thing as well. Dr. Newman did a wonderful job of sharing with us the details of the SIN score and the NOMS, which are an important part of my practice. And Dr. Angeloff has done a great job of talking about some of our treatment options that include CyberKnife fractionated radiotherapy. So what are our treatment options from a surgical perspective? Okay, we can consider large cancer operations, gross total resections, front back surgeries, but I would argue that especially in the realm of metastatic cancer to the spine, that's not really what we are supposed to do as surgeons, right? These patients have disease in many parts of in many parts of their body. This is not a curative surgery for them. So really the mainstay of our practice is decompression and or separation surgeries and stabilization surgeries. And we'll talk about the really fun ways that we get to do these types of surgeries. And I think really importantly, we talked about all of these different classification systems and what are the different factors that we consider when we're deciding on whether to operate on a patient. But the question is, given everything that's going on, their prognosis, their neurologic prognosis for recovery versus prognosis without surgery, what type of surgery we need to do to fix their problem. Does the patient even want surgery, right? That's an important question that I ask my resident if they're seeing the patient first. And then, of course, I ask the patient when I see them as well. So my principles take into account many of the ideas that have been shared with us already today. Consider the stability of the spine with the SIN score. Consider NOMS as an overarching framework, the age of the patient, but because we know that age is just a number, also their overall frailty and the goals of the patient. Even if it's in the middle of the night, I try to always have a direct conversation with that patient's oncologist. If it can't be their primary oncologist, at least whoever is covering for oncology in our hospital. And then my principle is to try to do for metastatic cancer to the spine, to do the least invasive surgery possible, especially in our increasingly elderly patient population. This includes navigated guided percutaneous fixation, cement augmentation, mini open decompressions, and separation surgery, and I'll share examples and surgical techniques now. So this is an example of a patient who came to me with metastatic prostate cancer and a very acute neurologic deficit. He presented to our emergency department as a transfer from another hospital in the Bay Area, 77-year-old male, heart disease, known prostate cancer history with the prostatectomy and now rising PSA. He came in with 5 days of lower back pain and progressive lower extremity weakness, now unable to walk for the last 36 hours. He's full strength in his upper extremities, and you can see he's quite weak in his lower extremities. His right leg is 3 proximally, 4 in his quad, hamstring, and plantar flexion, and 2 dorsiflexion EHL. And his left lower extremity, he's 2 proximally and 4 minus distally. You can see here an MRI post-contrast that shows that he obviously has significant disease present in multiple thoracic vertebral bodies. And this disease is present ventrally, but then he obviously also has this epidural component that's more dorsal that's causing severe spinal cord compression and is likely the cause of his acute neurologic deficit. So this is a type of patient that I think is important for emergent surgery. And in particular, this can be done really nicely with minimally invasive technique using stealth navigation. And I'll kind of go through the process here. You see here I did 3 above and 3 below. This is a relatively old case. I think I'd probably favor 2 above, 2 below at this point. And first of all, why do I use navigation for these cases? Chris has alluded to the importance of it's important to get these patients in and out of the operating room as quickly as possible. It's also important to minimize the blood loss. We also obviously want to place our screws with the highest accuracy and the highest precision, because even in surgeons who have been doing this for decades, mistakes can happen. We have looked very carefully at screw accuracy placement rates when you go from conventional placement free hands to 2D fluoroscopy and 3D navigation. And you can see that across all areas of the spine, cervical, thoracic, and lumbar, we have an incredible increase in the accuracy of screw placement rates when we go from free hands to fluoroscopy and finally to 3D navigation. So I'd say this is the equivalent of going from using a compass, paper maps, which I did used to use back in the day, to now GPS. I don't think any of us would go to a new country with our phones and not use GPS to get around. In our own analysis of over 50,000 screws, we found that CT navigation had the highest accuracy. And so when I'm doing stealth navigation, in particular for a case like the one that I showed you, which is the mini open separation surgery, we'll walk you through the steps. So we position a patient on the radiolucent Jackson. So in the particular case of a mini open surgery, we'll do a midline incision through the skin, use the C-arm to approximate the levels that we're operating on. And then importantly, we do need to place a spinous process clamp. So if it's a large fusion in this case, I would put a spinous process clamp both at the superior aspect as well as the inferior aspect of the incision, especially when I'm thinking about the kyphosis of the thoracic spine. If it's a shorter construct, you could only need 1 spinous process clamp. After you do that, you bring in the O-arm and you perform an O-arm spin. So importantly here, we have not opened the fascia, so we're not getting into any bleeding yet. So these are relatively low blood loss surgeries. Once we've done the O-arm spin and we can transfer the navigation over, and now we're using our navigated instruments, you can see here, we bring up what I call the navigated chicken foot, and we use this to plan our stab fascial incisions on each side. Use the bovie to get down to bone. Then we use a navigated power drill to drill the screw trajectory. I still use K-wires, and the reason for use, even though there's many companies that have K-wireless techniques for placing in percutaneous screws. The reason is that I like feeling for me, it's a way that I can kind of blend the feel that I get with open surgery and feeling the medial lateral, the bottom of my pedicle with the navigated system. So I use a navigated cannulated tap over the K-wire, and then I place a navigated cannulated screw over the K-wire. I do perform an intraoperative O-arm spin in order to confirm screw placement. And I'll talk a little bit about how that also factors into my cement augmentation and why that's important. And then, so in this particular case with this prostate cancer patient, so keep in mind, we actually don't have the fascia open in the middle. We've just done the stab fascial incisions on the side in order to place the screws. So then depending on the surgery that I'm doing, we can do the fascial opening in the midline. You can do the extent of both the laminectomy. In this particular particular case, this patient really only needed a laminectomy. We didn't need to go and get into the pedicles and decompress ventrally based off of his particular cancer. But as Chris mentioned earlier, for some of these patients, they may have a significant component of ventral disease for some of our metastatic cancer patients. And so then you do really need to do that more extensive decompression. After doing the decompression, we'll place the rods with the MIS rod inserters. I always will check my rod length so usually we'll start with a lateral C-arm just because that's what's in, but I oftentimes have to go to an AP in order to double check and make sure that both rods are long enough. And then I do use a navigated Midas burr to decorticate the facet joints. And then I use that technique in order to inject DBX because I think it is really important. We're obviously doing these cases in order to instrument and fixate the spine. We also need to be considering that these patients are oftentimes going to be getting radiation afterwards, as has been discussed. And so they're oftentimes getting multiple types of systemic therapy. So we do really need to think about the fact that these patients may not be the best patients to actually fuse. So any tiny thing that we can do during surgery that's relatively easy, even here in an MIS case, this can be something that can potentially assist with that. There are obviously pearls and pitfalls to these MIS navigation techniques, but I do think that they're ideal for hybrid mini open separation tumor surgeries like this one. We talked about the fact that you can use 2 clamps and 2 stealth stations if you have longer constructs. It's really important to optimize your clamp placement so that it is very close to the area that you were working on so that you have the highest degree of accuracy with your navigation, but also that it's not interfering with your screw placement. Always telling the resident or fellow who's working with me, as well as our nursing staff, to not touch the clamp because then your navigation will be off. And you really can have your navigation off with a lot of soft tissue retraction and manipulations. So you need to be aware of this. And I know it's not so much of an issue with cancer patients because they don't tend to be as large, although I did recently have a metastatic breast cancer patient with acute neurodeficit and a BMI of nearly 50 that I was operating on. So, even though we say that MIS is great for larger patients, there still is a limit to the size of patients that you can operate on with MIS. And so take this patient in particular. If you're getting too deep, what you'll see is that your instruments with the little balls that need to be seen by the navigated tracker can actually be deep in the patient and get covered in blood each and every time. So it's not a foolproof method for all patients. Okay. This is another example of a patient, and this patient actually had metastatic thyroid cancer with many months of, not surprisingly, lower back pain. She also happened to be a Jehovah's Witness. So for those who are not aware, they don't accept blood products, and we had a very extensive conversation because, as we've spoken about earlier, thyroid cancer tends to be one of the most bloody types of surgeries. So in this particular case, given everything that was going on with her, I did not feel that it would be feasible for us to do any type of open surgery for her, okay? Nor necessarily given the fact that she refused Cell Saver and all these other products after, hours and hours of conversations, significant debulking either. But we were able to do an MIS stabilization as well as a small decompression with less than 200 cc's of EBL for her, which then set her up for further systemic therapy after that. So cement augmentation, which has been touched on earlier, I think is a great adjunct, and I have been using it increasingly in my tumor patients, especially those who are undergoing post-op radiation. I also use it in my non-tumor practice for osteoporotic patients. And so when I'm doing this, I place fenestrated screws. And so those cannulated screws that we place over the K wires are fenestrated. They have holes that are towards the distal end as well as at the very tip, of course. And so when I'm doing this, I'll obtain a CT scan. So for me, that's an intraoperative O-arm scan. And I'll use this to confirm that the screw is perfectly placed, okay? This is much more perfect than what we would just accept if we weren't doing fluoroscopy, okay? There can be absolutely no tiny bit of medial or lateral breach that is actually less important than looking at anterior vertebral body violation because these holes come at the distal end of the screw. So sometimes the screw will look perfect and it goes just to the tip of the vertebral body. If I see that and it even, touches it, I won't cement augment that screw just because I'm worried about any cement coming out anteriorly to it. And the reason for this is obviously, especially in our metastatic tumor population, these patients are oftentimes immobile, they have cancer, they're much more prone to pulmonary emboli, et cetera. And I have seen a case of, in one of my patients, of a pulmonary cement embolus coming from the cement augmentation. And so after that happened, if you go and you kind of look in the literature, there's not as much literature from spine vertebral augmentation, cement augmentation, but there is from kind of vertebroplasty in the interventional radiology world. And there's some data that shows that maybe up to 30 or 40% of our patients may actually have asymptomatic tiny cement emboli after vertebroplasties. So what are the things that we can do to try to prevent that? So I use the highest viscosity cement that we have available. I inject small amounts. So basically the smallest, lower amounts of cement have been correlated with less likelihood of causing these cement pulmonary emboli. And then also very slow injection. So after I have verified perfect placement of the screws on an O-arm, I am wearing lead in the operating room. I use constant fluoroscopy. I inject 1 cc of a very high viscous cement, and I do it slowly with my rep actually counting to make sure that I do that 1 cc over greater than 60 seconds. Usually, quite frankly, it ends up being up to about 2 minutes for my technique. And so you can see here, very similar to some of the x-rays that Chris showed us, but you can see these nice little clouds of cement augmentation. And this is another metastatic cancer patient who was treated this way. So I wanted to share another case, which is a little bit different because this is not a patient who presented with an acute neurologic deficit where it's clear that that patient needed to go emergently to the operating room. So this is actually a different patient who I followed for a long period of time, and she was referred to me by one of our gynecological surgeons at Stanford. So 80 years old with stage 3C1 clear cell endometrial cancer. She's had a robotic hysterectomy. She's had chemoradiation, and she's had this C4 pathologic fracture. She's also pretty sick. She has had a recent pulmonary embolism, multifocal metastatic disease. She's been hospitalized recently for dehydration. She says that, this neck pain has been going on for a very long period of time now, a couple of years. It radiates into her biceps, into her forearms. When the pain's severe, she can't even lift up her arms. And at this point, it's really interfering with her quality of life. You can see she doesn't have a significant amount of spinal cord compression, and she has this, she also has overall degenerative spine disease, as one would expect in an 80-year-old, okay? So what should we do in a case like this, right? Her SIN score is borderline. She is a poor surgical candidate given her overall metastatic disease, her age, her frail appearance, her poor bone quality, and she basically just has mechanical neck pain, okay? So this is actually a patient that I treated for a long period of time in a collar. Okay. And she continued with her systemic therapy. She actually started to look a lot better from a medical perspective, but then she started to get worsening of her deformity and progressive neck pain. And finally, she said, I really just can't live with this pain. So after a year, we did end up taking her to the operating room and doing an anterior corpectomy and then posterior stabilization. Okay. And so this case was actually done open. And that's because we can do this very, very quickly and very effectively with this machine vision navigation technology that I also use in my practice. This is called 7D. So this uses similar technology as to what you have in self-driving cars. Okay, so most of us are probably familiar with, for example, the stealth navigation system from Medtronic, and many other companies have CT-guided navigation platforms where you need to get some type of intraoperative CT scan in order to, or at least fluoroscopy to merge that with the preoperative scan in order to use your navigation. So the difference here with 7D is that you have a preoperative CT scan, and then this light from 7D is actually a bunch of cameras that are taking an image of your field, okay? And then it takes that actual image and it uses that to co-register with your preoperative CT scan. So I'll take you through it really quickly. You position the patient, you need to approximate your level. Here you're doing an open exposure and it needs to be a meticulous and open exposure. You place your spinous process clamp very similarly to your region of interest. And so now instead of bringing in your intraoperative CT scanner, you bring in your 7D machine over the field, you take out all of your other lights, you get a very quick image of this, and this is called the flash registration. You want to see nice light around the part of your spine that you can visualize very well without blood, without soft tissue. Then you select points that are in your that are in your area of interest. And then you use that in order to co-localize with the preoperative CT scan. And so here, all of these green spots are, at this particular case, is a very nice registration. Of course, I'm showing you a good one that has like thousands of points that have co-localized. So now it allows you to, just like any other navigation platform, use a navigated probe to determine your screw entry point. You can do a navigated power drill and a tap. And then you can place a screw of any system using this virtual K-wire that they have here. So as some of the differences with the with other CT guided navigation platforms. So honestly, I feel like this is really quite good for open cases, okay, where large open decompressions are needed. You do have to do more of a meticulous bony exposure, so you need to be a little bit wary. I have done this sometimes in some cancer cases, and if you know that you are going to get into any cancer tissue in the posterior elements, then this navigation system is not the way to go, okay? Because if you need to stay out of the way of these tumor that's in the posterior elements, you can get into bleeding or get into tumor, and you're not going to get a good registration with this. So that is really an important thing to keep in mind, specifically when thinking about whether you're going to use 7D or another type of CT guided navigation in your cancer cases. But I love that we don't have to get an intraoperative O-arm spin, so that decreases OR time. It's really easy to get a repeat registration. You just get, it takes a couple seconds to take a new picture of the field instead of bringing in your O-arm if you have any issues with your clamp moving. It does, similarly to other types of navigation, increases your intraop radiation exposure. We haven't talked at all about carbon fiber, and we could do an entire talk just on this alone, but I have started to use these very routinely in my practice now. So carbon fiber screws obviously are nice. There's two different kinds, and I'll show you sort of the differences. This is the one that we do have on our formulary so that I can use at Stanford. But you can see it on a CT scan, okay? So because there is a tiny amount of metal in this particular one, that's around the threads. So you can see the placement of the screws here. You can still evaluate that effectively. And they're definitely a bit harder to see on an X-ray. Our residents call them the ghost screws, but you can see them here. So of course it's difficult to see if there's loosening or to exactly evaluate their location on an X-ray, but you can on a CT scan. And then here, the real advantage of using these is that they have significantly decreased artifact on the postoperative MRI. So our radiation oncologists are not necessarily needing to get the CT myelograms, and they can do their plans for the postoperative radiation with the MRI. And you can see here what the postoperative MRI looks like for a patient that's had these carbon fiber screws for one of our cancer cases. And they are very expensive. So I have started to do hybrid constructs. So you can see here what that looks like. So not only are they very expensive, but also the screw heads themselves are much larger and they're more finicky and harder to maneuver. So I will place the carbon fiber more expensive screws closer to the area of the tumor that's going to get radiated, where the artifact really matters. And then I'll place regular titanium screws further away. And so you can see what this hybrid construct looks like. And these are carbon fiber rods that are placed through And another thing to think about, not only are these screws a little bit harder to use and maneuver, but also you cannot bend these rods. So you can't necessarily do like a 12 level rod. This is pretty pretty impressive. We were able to do 1, 2, 3, 4, 5, 6, 7, 7 level with the rod and not bending it. So it has to fit completely perfectly. And you can see here the difference on the MRI between the artifact for the carbon fiber screw versus a standard titanium screw. And these are just a few MRIs from our patient. This particular patient, you can see the different levels. There are 2 different types of carbon fiber screws if you're considering bringing them into your institution. So as I mentioned, the one that I showed you images of has a little bit of metal around the screw head and not, around the screw itself, the threads of the screw, but not in the screw head or the rod. And there's another one that's available that has a little bit of metal in the screw head, but not in the screw itself and not in the rod. So you can see on the top the X-ray from the one that we've been using, and then you can see at the bottom that you see a little bit of the radio opacity at the head of the screw for the other one that's available. And it too has very nice profiles in terms of post-operative metal artifact. Last but not least are expandable corpectomy cages. I think these are a great technical adjunct for our tumor cases when we're needing to do more work, okay, not necessarily a pure separation surgery, but if you have, so patient here, this is a metastatic angiosarcoma of the breast with some ventral compression in the cervical spinal cord. So you can see here, a titanium expandable cage is a great option. A vertebrum planum situation with severe cord compression, this in a setting of multiple myeloma, also a great option. And, we do have both PEEK as well as metal options for these expandable cages. I do like to get, if I am doing these cages for metastatic cancer, because I know these patients are oftentimes going to have poor bone, have had radiation before or after surgery, I like to use cages that have good spikes that can really get into the bone. And then I haven't used these yet, but this is an exciting new option of these carbon fiber expandable corpectomy cages as well. So in conclusion, the most important aspect of metastatic spine tumor surgery is determining whether spine surgery is even indicated and appropriate for this patient, right? My personal principle is to do the least invasive surgery possible for frail cancer patients. And percutaneous fixation with decompression and separation surgery is a big mainstay of this. Navigation is the standard of care in my practice, either more routine navigation platforms like Stealth for minimally invasive cases, or I oftentimes use machine vision for an open case. But as I mentioned, for an open tumor case, if there's a lot of posterior cancer, that may actually still be much better done with a Stealth navigation. And then really important adjuncts include cement augmentation, carbon fiber screws, and expandable corpectomy cages. So thank you again for this invitation. Here's my email, my cell phone. I am available on WhatsApp. And for anyone who's going to be joining us in spine section next week, I would love the opportunity to meet you. And thank you again to WFNS for this opportunity.
Thank you so much for your last presentation of this first part of this beautiful session of spine metastasis. Good presentation, very huge, very comprehensive. I should ask you a question and make a comment. The question is, why didn't speak about neuromonitoring, which is mandatory in order both to check the roots by intraoperative electromyography and long tract sways with motor evoked potential, mainly in unstable, virtually unstable metastatic spine. I think that should be strongly indicated. And second comment is about vertebroplasty and cement augmentation. Correctly, you suggest fenestrated screws. Otherwise, you know that fenestrateds are more weak compared to the classic strong screws. And in my experience, I prefer to put cement first through the pedicular hole and immediately after to put the screw. What's your experience about this option? But first, what about the neuromonitoring?
Yeah. So I didn't speak about it, but I use neuromonitoring routinely in almost all of my spine surgeries. Across the board, whether it's tumor or not. So if it's I use it for all of my cervical surgeries, pretty much regardless, anterior and posterior. And I would use it for any of these cases as well. I mean, I even use it in a posterior L4 to S1 decompression infusion. So it's pretty much standard of care at our hospital. So would definitely use it. And then great point about the different ways of doing the cement augmentation. So actually, yes, in my training, so I trained at UCSF and I worked a lot with Chris Ames, who's one of our deformity surgeons. And the way that you described the cement augmentation is actually the way that he did the cement augmentation for the deformity cases. So basically at the UIV, the upper instrumented level, and the upper instrumented level +1, what we would do is we would put in our screws at the upper instrumented vertebral level. We would just put in a pedicle marker. We would obtain an O-arm spin, assuming it looked perfect, inject the cement, and then put it in. And I did, I think when I was his resident, we looked at a paper which was published showing that technique was safe after we had gotten the intraoperative O-arm confirmation. So I think it is, obviously a very valid way of doing it as well. So yeah, I think there's a lot of different approaches, but yes, we did do that. And I know we have actually published a paper on it showing that it works well. This is the way that I have been doing it in my practice, and in particular for the tumor patients.
Yeah.
Thanks.
Dear Massimiliano, I think we should finish that session. I thank all the speakers because we have time constraints. We exceeded the time.
Okay, thank you. Thank you.
If you want to comment on some points, then we can start the second session.
No, I'll request the speakers to answer in the chat box so that we can go on to the second question. We can go on to the second session.
Yeah.
Yeah.
Um,
I'd like to thank all the speakers for giving a very good. Yeah.
I also thank all the speakers for their very valuable lectures on metastatic spine tumors.